Okay, so we have had lunch, or we're still eating lunch, which is fine. So a reminder, it is fine to eat and drink in the room. Next, we're going to have the research panel. So we're going to get an update on the latest research. Each of our 4 panel participants will talk to an individual slide first, just give a specific update, and then we'll have a conversation, and there will obviously be room for questions for everybody. So that will come. After that, we will then have a very short briefing on the SafeSite Institute, why we're here, what it's for. And then we will go, and then Professor Grigg will do some closing remarks. After that, we will then move into our breakout sessions afterwards. So that's where we are today. Let's do a bit of a intro. Do you want me to intro all 4 of you all in one go? Okay, here we go. Our research panel today is Professor John Grigg. He's Professor of Clinical and Experimental Ophthalmology at the University of Sydney and group leader of the Eye Genetics Research Unit at the SafeSite Institute. His research interests are genetic eye disease, glaucoma management, and electrophysiology of the visual system, with applications to upcoming clinical trials. And he has a very tight relationship with SafeSite Institute as well, which has been forgotten. Professor Robyn Jamieson is the head of the speciality of genetic medicine and Professor of Genomic Medicine at the University of Sydney. She leads the Eye Genetics Research Unit at the Children's Medical Research Institute, the Children's Hospital at Westmead, and the SafeSite Institute. Her team's genomic and stem cell research is leading to transformational opportunities for new therapies in genetic eye disease. Associate Professor Elisa Cornish is a consultant eye surgeon, staff specialist at Sydney Eye Hospital and Westmead Hospital, as well as an associate professor at the University of Sydney. She is actively involved in ophthalmology registrar and medical student teaching, and is part of the Inherited Eye Disease Unit at the SafeSite Institute, where she has a special interest in electrophysiology. She's actively involved as an investigator in clinical trials of new therapeutic agents to treat blinding retinal conditions. And Dr. Alan Ma is a clinical researcher and educator. He's got more than 10 years of experience as a geneticist at Sydney Children's Hospital Network. He is lead CI for PRECISE, an MRFF project for genomic implementation in primary care, and he co-chairs the Sydney Health Partners Clinical Academic Group in Genomics and Precision Medicine, with a focus on implementation science and studying the mainstreaming of genomic healthcare. I almost got through. He is Program Director for the Masters of Genomics and Precision Medicine at the University of Sydney. Makes me feel tired. You guys do a lot. Okay, so each of you has got 1 slide to talk to. I will step away and I will come back for the conversation.
Perfect. Okay, does that work? Can you hear me?
Yeah.
Hello, everyone. So thanks very much for the fantastic introduction. And it's so good to be here today again and catch up with people and meet new people and, really engage with people about, the various issues that we're trying to deal with here. I've put up a summary slide really of our vision research pathway and pipeline, because really what we're aiming to do with our vision research here at SafeSite and all of our associated institutes, Children's Medical Research Institute and the Sydney Children's Hospital Network and all of the hospitals around the state, is we're really trying to take things from the patients and really understand the clinical phenotypes for people with these types of conditions, and then as far as possible be able to make a genetic diagnosis. And so from the laboratory perspective, so in addition to my clinical role, I also run a research laboratory, which I just wanted to let you know a bit about. So what we're doing is really try and help people where we don't have a genetic diagnosis. So sometimes that requires high-end genomics to see if we can get a genetic diagnosis, because that is so important in terms of feeding into the clinical trials and so on that Lisa and John are going to be talking about. But then also sometimes, no matter how much genomics and looking at the genetic sequence we look at, we can't get the answer. So in some cases, we're doing what's called functional genomics, which is a big word, but basically what we're doing, and I know that some people who are affected with the condition and that we know and are part of our team, the patient team that we see at Save Site and also at the Westmead, we're actually taking blood from those patients and turning them into stem cells and then turning them into little baby eyes in a dish. And then we're doing research studies on those eyes in a dish to understand how the genes work, but also to look at the genetic variants to see if we can have more of an understanding of are they actually disease causing or not. And in some cases, that's allowed people to actually have a gene therapy, which they couldn't have without that work, because they became eligible for the gene therapy. And then the next part of the work that we're trying to do is develop gene therapies for conditions where they're not currently available. And since there's over 280 disease genes in the genetic retinal diseases, and actually only one clinical gene therapy available for the RPE65 gene, then there's a lot of work to do. There's over 279 genes that we're interested in looking at, but of course each of them requires a lot of detailed work. But we have made a lot of progress. And in fact, we've got 3 genes now that we've made a gene therapy for. We've been able to look at them in patient retinal organoids and see that they're actually making a difference in the dish. And so what the next step is that we're wanting to do is to be able to take that to clinical trial and then to be able to offer that as a therapy. And that's, of course, that's work that we're doing in our lab, but of course we're also very aware of work that's done around the world, and we also want to capitalise on work done around the world and bring those clinical trials to Sydney as well, if we possibly can, which Lisa and John are going to be talking about. So the whole aim is then to be, getting the therapies, getting the diagnoses, and making things, doing the improvements as we can for people affected with these conditions. And part of the work has been, we've been working with the New South Wales government to get a better pathway for how patients with genetic eye conditions, so retinal conditions, but also cataracts, anterior segment, all those other genetic conditions, getting a better referral pathway for that. And I'll be handing over to Alan to talk about that. And as part of that, we've done a lot of work with the people affected with these conditions. It gets called consumer engagement, but of course it's basically working with people affected with the conditions, which is clearly incredibly important. So I'll hand over to Alan to be talking about that and the educational aspects that go along with that. So thanks, Alan.
Thanks, Robyn. Oh, can you hear me okay? Excellent. So my name is Alan Ma, and yeah, I think there was a lot of jargon in my introduction, which I wrote, which I probably shouldn't have put in there so much, but I'll explain a little bit about what I do. So I work as a clinical geneticist. I see patients with genetic conditions, a lot of them with eye genetic conditions, but I also did a PhD research project under Robyn's supervision on genetic eye conditions as well. So my real interest is in something called implementation science, which sounds really fancy, but it's really about how we get all these advances that you're hearing about, the gene therapies, the genomics, the diagnostics, actually into reality, into the health system, so that GPs, other doctors know how to help their patients access it, and also so that patients can understand what this is, what the promise is, maybe look and carefully work out whether they want to have this or not, and also how to access the therapies and the things that are coming along. So I kind of see this as working on several levels, so at the patient and consumer level, at the clinician level, so the doctor level, but also at the health system level, because each of those levels have different challenges and barriers to really helping to facilitate this to become standard of care, which is what we all want to happen. So at the patient level, I do a lot of co-design with patients, working with patients and consumers to understand what they want, how they want them delivered. So right now I'm working on a project with patients and GPs to work out how they want genomics to be delivered in primary care. So when you see a GP, they know how to handle this, and so that it's helpful for their patients. Over the last few years, a lot of us were involved in a patient priority setting exercise where we worked out with retinal disease patients around Australia, what are their top priorities for research? What do they want to actually us to focus on? And unsurprisingly, the number one, and I think the number 3 and 4 things were gene therapies. They want therapies for these genetic conditions, which is totally understandable. But there are other aspects of the research that they wanted, like the supportive care around this, the psychosocial, so psychological help and support, around these blinding conditions that can often be quite serious and have implications for the rest of the family as well. At the clinician level, there's a lot of challenges just in terms of basic genomic education, that a lot of this genetics has advanced over the last 20, 30 years much faster than education has advanced. And so a lot of my work is actually educating doctors, ophthalmologists, surgeons, medicos and GPs about genetics and what it means for them and how they can access this for their patients. And we run masters and courses to help them do this. And I guess the third area is to really look at the health system, because a lot of this is actually putting extra pressure on the health system and a lot of challenges. How do these new technologies actually get taken up, paid for and implemented within the health system in a fair and equitable way? So part of that work you'll see here is the inherited retinal disease pathways work that we did with New South Wales Health, which is basically just trying to set one pathway so that any doctor or any patient in New South Wales with a patient with this condition go, oh, what's expected of me? What is the next step in that pipeline? Where do I need to go next? Where do I need to refer? Where should I be able to access testing? And so hopefully that will help streamline a lot of things, because up until we wrote this, it was actually quite unclear and quite inequitable about what was done depending on where you were seen. So I'm interested in those kind of 3 levels of how we implement things into the health system. I'll let Lisa take over next.
I'm green, you should hear me. So I am a clinician and see the patients in my room. But before they get to that point, I am involved, which was mentioned earlier, on the electrophysiology, which is where we test the function of the retina, the cone system and the rod system, so the light, the dark adapted nighttime vision and your high acuity vision. And so I'm involved in that a little bit, but then when I see the patient, my patients always ask me, is there any, can I get an eye transplant now? And originally, when I started training, and as Alan just said, things have changed so much in our genetic medicine that when I started training, we had nothing to offer. And it was kind of like, yeah, eye transplant. But now there are therapies, and it depends on what stage of the eye disease the patient's disease is to what kind of therapy fits for them. And so I've got a couple of slides, and it's just showing if you press arrow, if it's early in the disease, in your disease, you still have good anatomy and good parts of your eye that are there to get some gene therapy, then they're the ones that will respond to things like gene therapy, because the building blocks are still there to be changed. But in the second slide, we go across again. Sometimes you get to see a patient or meet a patient when the bottom picture is showing there's not really much building blocks there in the eye to work with. And the other kind of therapies and treatments that are under investigation look at trying to help these patients see when they don't have the building blocks to switch the gene back on. So those kind of things are like the optogenetics, which I'll explain in a minute, and some stem cell therapy. So that's replacing the building blocks that are there. So there's a broad range, and that also includes things that you hear about with like a retina transplant, or where they put in a little camera in the back of the eye to help you see. I mean, that's where you have to replace the building blocks because there's nothing left there to use. And at SafeSite, John and I are with about 6 or 8 clinical trials currently, which are working at different stages of all these type of therapies. And one of them is Abacus 2, which is using the existing building blocks that are there that are not normally the ones that receive and recognize light to turn on to recognize light, so that the building blocks that are left can actually do something for the patient to be able to see. And it's at the moment a really stage where they're like nearly no light perception. So it's early days, but the idea is the treatment that we use, which is actually an injection into the eye, may help them see light, which is a big step if you haven't seen light.
It's IRD slides.
IRD, so inherited retinal disease, so retinal dystrophies.
That's your last slide.
Oh, that's the last slide. Oh, that slide. That slide is showing more of when you've got no anatomy to work with, that's when you will bring in things like a transplant to help you see with a camera at the back of your eye, or things that you actually need to replace.
Actually, so my discussion this afternoon is about the therapies that we've come to. And really, the team here is sort of integral to all the clinical trials we've had, because we have two broad areas of therapy. There's sort of generic therapies that support retina structure and support the cells that are there. And then there's genetic therapies that try and change or correct the changes that are there. And Lisa's given a nice overview of how the different therapies go. But to give an update on two of the trials that are coming close to the end, there's a Be Like Bio Tinlarebant study, which we heard from Olivia this morning. She was the first in Australia to be on that study. And we've so far, that's showed slowing of progression by 50% for people with early Stargardt disease, which is quite a substantial improvement in their function. And so that's sort of the phase 3 study is being concluded this month. And so we'll hear some data from that. But there's been very promising preliminary data that the FDA has then granted orphan drug status to that. So that's exciting time. There's another study that we've been doing, another supportive molecule through a company called Enacuity. Again, this has been an Australian-only study, and that's looking at people who've had Usher syndrome with the retinitis pigmentosa that goes with that. And that's trying this molecule called N-acetylcysteine amide has one that preserves cone function. And people with retinitis pigmentosa, the rods are affected by the genetic cause, and the cones are then secondarily affected. If you can preserve the cone function, then you can preserve your central vision. And so that study ended in June, and it met 2 of its 3 outcome measures, which was very exciting. The FDA says they wanted to repeat it to sort of qualify that, but right now you can buy the precursor of the trial drug online without a prescription. And so that's what we're recommending to all our people with who have retinitis pigmentosa or cone dysfunction. So that's an exciting time. Basically, the next steps are that Lisa's highlighted one that, so there are people with recognized diseases, but there's a group of people we've got really end stage vision loss. And that's the group that the Abacus study is really exciting for. We keep people who maybe previously have thought they'll never have any treatments. We've now got a treatment that looks very promising for them to return some sight. The molecule can come in and pass on to another part of the pathway and then utilize the system, because I suppose it's important to remember that the retina captures the eye, but it's your brain that does the seeing, and you need the messages to get to the brain. And that's why stem cells are still challenging at present. But it really takes a big collaborative process to do this with the genetics and the diagnostics to do this. So now I think after that little introduction, we open up for questions.
Clinical trials. I know that I'm on Facebook, on a few Facebook groups to do with RP. My mother has it, I have it. One thing, apart from, the latest supplement, and unfortunately, there's generally no guidance on what's good, what's not good, what's in, what should be out. So that's another issue as far as I'm concerned. But the one thing that people will talk about endlessly and search for endlessly are any clinical trials. There's forever chatter about who's got this, who's in there, it's all happening in America. It seems something in England, maybe something in Canada. We never hear anything about Australia. And I know people are desperate for any kind of information.
why we're here. That's absolutely why we're here today. And I think this has been talking about some of the trials that are actually happening in Sydney. I think there's a lot of work happening in Sydney and in Australia now. I think it's sometimes hard to get the companies, we have endless conversations with companies about coming to Australia. And unfortunately, we've got a small population. So they criticise us for our small population. You kind of go, well, come on, guys. We
matter
here. We've still got patients, and people really want to engage with you. And some of them are coming through because actually some of the genes, for instance, RPGR, it's actually been the subject of at least 3 companies involved in a particular therapy. So actually, UK and America, like some of those places, they've run through a lot of their patients, so they actually don't have patients. But they're looking at other sources. So I think it has been frustrating. I totally get the frustration. We're completely frustrated as well. But I think it's changing. We'd all like it to change faster, of course. But I don't know, Lisa and John.
I think, following on from Robyn, I mean, Australia is actually a very attractive place, and partly it's due to the work of Robyn and Alan to do the genetic typing for genetic therapies. You have to have a genetic diagnosis, and that's the work that Robyn and Alan have really done, and that's why we're now receiving these companies coming to Australia, because we have people on our registry who've got these conditions, and so we've been selected as the only site for a study for a trial for a rare form of Leber's congenital amaurosis, where we have all those people are here. There's only 5 people in Australia with it, but they'll come for those people. There's more studies coming for Stargardt disease for different types of genetic therapies. So the challenge is that the trials, to get an answer, they need very tight criteria, their age range criteria, because they've got to show change. As you know, most of the conditions change very slowly over decades, but they need to measure change over a year or 2 to make it economically viable, to be able to get government decisions and things. And that's the challenge of, we need people at particular times in the condition. So, but there is actually, and the Australian government has a very good tax incentive for this. So they actually, for R&D, they can almost make money here. So it's a long way for them to come, but they're getting the idea. So those studies we mentioned before, they're world leading. Nobody else has done the inacuity study anywhere else in the world. The Tinlarebant study was done here and in Taiwan, but nowhere else in the world until this phase 3. So there's been places only done in Australia.
And I think just that you only ever hear about America. It's, that's why we're here today. I'll tell you about Australia.
We're doing them.
Yeah.
And then of course you hear about those gene agnostic things where, it no longer depends on this variation or that variation. So there's a lot of talk. There's constant talk about this on not just Facebook. I'm sure it's probably just for the boomers. I don't know if they're on Instagram, who knows? But yes.
Well, that's the Abacus study. That's gene agnostic.
Yeah.
There's 2 companies that are coming with optogenetics. We've got to evaluate that. And that's where we need the whole team to look at, would you like to have a small molecule that will change, or do you want a genetic therapy that will reprogram cells? There's a lot of different questions, and that's where we need the expertise on the panel here, because we don't want to. You don't want anything to be worse than what you've got.
Okay, we've got a question over here.
Yeah, I'm actually asking just a general question in terms of, I know you're doing research into gene therapy and the makeup of how these diseases work, but are you doing anything in terms of the research of technology? For instance, I was on a holiday with people who were vision impaired or blind last year, and somebody who was sighted came along as well from America who works for Sony. And Sony have created this retinal camera. And some of the people who were blind, completely blind, they actually could see a landscape once they put this camera to their eyes. So is there anything that's happening in that sort of a space in Australia as well?
we've been, the most recent sort of thing is the Meta AI glasses. And I think it'd be interesting how many people have used that here. How many use Meta AI glasses? Yeah. I mean, I've had a lot of,
The Ray-Ban things.
yeah,
And they read to you, right?
yeah. So there's, yeah.
I used to, this is a physical camera taking device.
I've just had feedback really in the last month about the version 2, the second generation AI seems to be amazing.
Yeah.
This is where they've fitted AI technology, but yeah.
Involved in that sort of research.
We're not evaluating that, no. But for those who haven't heard of the Meta AI glasses, so it's Meta who makes behind Facebook, and they've fitted their AI technology to Ray-Ban glasses or Oakley, and rather than the other way around, there's other AI devices that have to fit the glasses to their device. And it seems to be, you can read train timetables, bus timetables, it'll read menus to you. It'll recognize faces sort of thing. So if you're at a coffee shop, I think I probably need that myself, but
This is Robyn coming over for a coffee.
yeah, probably coming over for coffee. But then somebody did say to me, well, if I want to read my child, I have to listen to it and then speak it back. That was a thing, but so there is that's I think coming into the area. But yes, we haven't been doing that sort of research, no.
No.
People being born with vision impairment and blindness, or is it stable, or is it?
Genetics perspective, there's actually been a bit of a revolution in terms of reproductive carrier screening. So I'm not sure if you might have heard of this mission or that's a project which was looking at having carrier testing, autosomal, carrier testing.
To see if, for autosomal recessive, so particular types of genetic conditions, we're all carriers. A carrier means that, so we've got, 40,000 genes, say, so we've all got variants in those genes, which make us all look different. And so that's our genetic makeup, which is doing those things. But sometimes some of those genes have variants in them that are damaging. And sometimes we have our genes and we get one set of our genes from our mum and one set of our genes from our dad. And sometimes if we've just got one of the sets is a problem, there's a problem there, then that's okay. We're not getting an issue. But if our partner has a change in that same set and then a child has those two sets that are changed, then they can get the condition. And quite a few of the genetic diseases, the genetic eye disorders, are inherited in that sort of manner. I mean, there's other inheritance patterns, but for that particular type of inheritance pattern, there's reproductive carrier screening can now be offered. Fortunately, it's not available necessarily free to people, but they can pay money if they want to, and test, am I a carrier for a particular, bad, difficult condition, and is my partner a carrier for this particular condition, and therefore could I have, something in a pregnancy that might mean that I might have an IVF pregnancy and then I might have pre-implantation, what's called pre-implantation genetic diagnosis, and then I mightn't have an affected child. Now, there's all sorts of issues, of course, related to that in terms of, do you want to do that? What's the ethics of that? Is that a reasonable thing to do? Who knows? Well, people have their own opinions and, everyone, this is something that's not mandated. It's something that is offered to people, and they take it up after, consideration if they want. But because of that type of thing, it's possible that the frequency and the prevalence of these sorts of conditions will decrease. Now, I don't think, it's early days yet. And what we don't know is, are people actually taking that up? Is that perceived as, you know, is that something people want to do? Or do they want to say, no, I don't want to do that. I want to, have children as I want to have children, not, some preconceived sort of notion about that. And I don't think there's been a lot of prevalence data yet to see what the impact of that is. So I guess we're in a bit of uncharted waters there in terms of how that goes. But I guess that is something that could impact the question that you had about the prevalence of these conditions moving forward. But I guess my expectation is not everyone will want to do that. Not everyone will see that as an appropriate path forward. And there's lots of issues with having babies, as we all know. And so you can possibly be looking at one thing, but actually the child could have some other thing that you weren't expecting. So there's all sorts of variabilities and about that. So I guess we don't know, but these conditions are generally genetic. So they will be there.
I think
The
that
retinopathy, ROP, retinopathy.
Retinopathy of prematurity.
That's
That's decreased. That's decreased. That's because in the 50s and 60s, babies were given, or maybe even a bit later than that, baby was given too much oxygen
Preemie
when
babies.
they were babies. So, but that's definitely decreased. Yes.
the other thing that's going to affect the prevalence or the numbers is the imaging that we have now is so readily available in our optometry settings. So people might not have found out for 10, 20 years that they had anything wrong with their eyes. Whereas now you go just get your glasses checked, they do a picture and all of a sudden you're like, what's that change there in the periphery? So I think
that's the extra test that you pay, isn't it? To look at the
yeah. So I mean that kind of thing
is of course worth every cent. And you're always asked that question, that would you like to pay the $70 for the external testing of the retina? And of course that's really important.
Yeah.
That's done.
But I just
Not
think
everybody will choose.
no, but I just think that it's more readily available. Like even if you go to the ED now up the road, they'll take some pictures if you've come in with an eye problem. And so I think it's going to change the prevalence numbers for a bit because we never used to have all this imaging stuff.
There was another question in the row behind. Yeah.
Thank you. I'm a white middle-aged male with short brown hair, crew cut, brown beard, a little bit of white in it. I'm getting on. Blue eyes and I'm wearing a blue t-shirt. First of all, thank you all for everything you do. I really appreciate all the efforts that you put in. And I can't put it into words how much we appreciate what you do. Two questions, one real quick. Dr. Grigg, you mentioned a supplement that would help with cones and rods. Can you let us know what that is, please?
That's NAC for abbreviation, or N-acetylcysteine. It's a very complicated chemical name. It's been used in medicine for more than 50 years. It's been commonly used to treat paracetamol or Panadol overdoses in hospitals, but it's got good evidence that it preserves cone function. And now we've got some clinical trial data that's very strongly supporting that.
Thank you. And then the other question is genetic sequence.
Before, it's been used by all the bodybuilders recently.
Yeah.
So we expect a lot of six packs next year.
The other question is with genetic sequencing. My partner's been put on a list. It's 2 years to wait just to get the sample taken, I believe. Why is it so long? And then what does it involve? Is it simply a blood test, or can you explain that, please?
Yeah, I can talk about this. This is what keeps me up at night. So currently at our hospital, the wait list is 5 years to see a geneticist. It depends. In Australia, there's a bit of a postcode lottery at the moment, depending on where you live and how well serviced your local genetic service is, depends how quickly you're seen. Genomics is exploding in every area of medicine. So not just eyes, cancer, kidneys, hearts, every organ you can think of, there's now a genetic test for it. And so the number of genetic referrals has kind of gone like an exponential graph. The number of geneticists in Australia has flatlined. There's 250 of us. So I calculate on the back of an envelope, it would take 50 years for us to see everybody in Australia with a genetic condition, because about 8% of the population have a genetic condition. So it's a real problem. I totally hear you. And that's what we're doing a lot of work with consumers. And that's the number one thing they're telling us, that getting their GP to understand this and refer them to the right person and being listened to and then getting access to the test, it's a nightmare. And it's taking 5 to 8 years from the first thought, oh, could I have something genetic, to actually getting the test and getting a diagnosis. So it's a real problem that we're facing at the moment. There's a few things that we're trying to do in research and talking to the government to try and fix that. There's a few things that patients can also do to help with that as well. At the moment, there is a growing number of private genetics options as well. So we're training a lot of geneticists, but the public system's not giving them jobs. So there are private options. At the moment, we're trying to work out how to help our non-genetics colleagues do some of that genetic testing to take a bit of the pressure off the public waiting list for genetics. So that's something called mainstreaming that you might have heard mentioned before, that we're trying to help our cardiology colleagues or our renal colleagues or our pediatric colleagues to actually do the first couple of genetic tests or do the screening tests, so that so that they don't have to wait to see us before that test gets done. And I think the other thing that we're really trying to do is we're trying to hear from patients and lobby for the government to actually fund genetic services properly. That, we're still working on the same funding we had in 1999, and that's clearly not good enough. And we tell that to our hospital regularly, but we want our patients to also say that as well. So we've had patients writing to their local members. We've had patients writing letters to the hospital. We really want to mobilize this, because we know that our patients are being hurt by the fact that our hospital system is just not agile enough to meet the needs right now. So I'm happy to talk to you later if you want to talk about this, but there are groups like Retina Australia and Cure Blindness that are also lobbying and trying to push, this kind of work. Some of the pathways work that you saw earlier is to try and help so that you don't bounce around, multiple GPs and multiple ophthalmologists before you get the right referral to genetics, so that you have a more streamlined path. But yeah, it's a real problem at the moment, and there isn't an easy fix right now, but we're trying to make as much noise as we can about it, because it's a problem then that impacts patients, obviously. It impacts the next generation. If you don't have a diagnosis, you don't know what the chance is of passing something on to your children, and you don't know what your chances are to accessing a trial or a therapy that might target that gene. So there's all these knock-on effects, and we really need to try and fix that system.
Are doing genetic diversity, or are we losing into places like the United States?
Yeah.
By jobs.
I know we're actually putting genomics into the medical curriculum now. So Sydney Uni has genomics in the medical curriculum, and we run a master's program. So we've trained probably over 100 different doctors over the time in genomics as well. So there is work being done, but clearly it's not fast enough and not enough at the moment to meet the demand. The demand is huge.
I think I should ask the AI question. Given how much they talk about AI helping with looking at scans of lungs and cancers and things like that, other than generating useless videos of dancing people, does it help at all in speeding up the work that you do or taking burden off yourselves?
Yeah, I think, well, from the genomics perspective, I guess you guys can talk about the ophthalmology perspective, but from the genomics perspective, there's been a lot of work in the AI space. So as we've been talking about, we're now doing genomic sequencing. So, I guess 15 years ago, probably, the possible testing that was available was to sequence one gene at a time. So, for instance, the IIDs or the anterior segment dysgenesis disorders, they've got a lot of genes. So actually, basically, patients couldn't be offered anything really, because there were 280 genes, and if you were sequencing one gene at a time, each gene cost, $2,000 to sequence. 2,000 times 200. That was a heck of a lot of money that the health system certainly wasn't going to pay for. And then the whole genomic sequencing came along. So that's actually been an absolute revelation, and AI and bioinformatics is used for that to analyse the variants, but there's still a lot of genetic variance. It's still an enormous amount of work, and when you come down to tin tacks of, you know, what does that variant doing, you do still need, you know, people at the end of that, and we run an ocular genomics multidisciplinary team approach. We're doing that virtually now, where clinicians from all around New South Wales or Australia can contact us and talk about a particular case if it's particularly tricky. You know, AI helps in that to a certain extent, but still at the end of the day, you do need the human eye across it to say, you know, is this correct or not? And then in terms of talking with patients about interpreting that information and what does that mean for them, you know, again, AI is helpful because people, you know, can obviously Google things and look things up and understand them. But, you know, in terms of, you know, what it actually means for them, really a face-to-face, you know, a discussion is really incredibly valuable with people to really answer their questions and have a feel for, you know, where they're going with things. Don't know if you guys want to answer from the...
Well, ophthalmology in general, it's good for screening. I mean, we use AI, but you used to have people, particularly without access in Sydney, if you're out in the west, then there were clinics that you take photos, as I was saying before, send it to someone here and we do the screening. But like now there's programs being set up for, say, this is in diabetic retinopathy. The AI itself is screening and flagging the ones that need to be then seen one-on-one with a person. So that's all I think.
That's right. One of our master students, Lisa and I, are involved in running an ophthalmic basic science course, and he's set up his own company and now got FDA and EMA, the European agency, and TGA approval for AI assisted diagnosis of diabetic eye disease, glaucoma, and macular degeneration and cardiovascular risk factor. He was visiting us again last week. He's now based in New York because he's got serious money there, but he's coming back, and we hope to have some trials here for that. Because that's one of the big challenges, as Lisa was highlighting, that those common diseases like glaucoma and diabetes, they have a long lead period before you lose vision. So if you can intervene, you can save sight. But you've got to find those people, and they've got to come and be tested. And it's got to be done in an easy way.
Got a simpler question. So my hazy amateur memory of last year was that there was quite exciting news that there'd been an RP trial that had kind of gone mainstream. And I think they said there were 11 people who'd had it injected into their back of the eye. I remember someone was in the audience that said, no, actually 12, that's me. I got done 2 weeks ago. I can now see textures or fabrics, I think was the answer. How is that going? That was pretty big news.
Yeah, that's still going. We're still doing that. So there's 14 patients now, and yeah, all generally speaking, improvement. Yeah.
His first person was done.
This one's Luxturna, RPE65 gene therapy.
But that's really kind of niche, isn't it?
Well, it's that's exactly right. It affects the people with the got to have the variants in the RPE65 gene. I guess we see it as being the vanguard in a kind of a way. You know, it's been demonstration that you know has really made a difference for people. So you know, we'd like to do that for many more people. Is there another trial that you were thinking of there?
I mean, I know at some point there was something in South of Face a few years ago now.
The Cura. Yeah, the Cura.
I don't know whether it ever made it. Yeah.
That's now called Abacus 1 and 2.
Yes.
That's what we're doing. I did the first injection
last week.
Yeah, very exciting.
Yeah.
So what is Abacus in dumb terms, like me?
In dumb terms, the eyeball, the cells in the eye, in the retina, that usually see light are not there anymore to see light. And we're trying to switch one of the cells that are still there, that are connected to the brain, to see light. And so the patient that I injected obviously can't see any light. And he was super excited because he thought, wow, this might actually change something. And so we did the first injections last week, yeah.
That's through stem cell, sorry. Is that through stem cell? Were you, I just watched 2 days ago something about stem cell through New Uni as well, SSI Institute. and they were speaking about stem cell.
That'd be the corneal one.
Corneal, yeah.
Disease.
Yeah, so front of the eye, cornea. Yeah, there's stem cells everywhere, but they've got some too. So I think that's that one.
There's a session coming up that Professor Watson's organising on corneal stem cells. That's in the next week or so.
Okay.
So it sounds like in general, the treatments we've been talking about the last few years, they're going into humanised now, not animals. Those trials in general are not failing. They seem to be succeeding. We're not quite at the level yet at which we can just say any GP can go and pull out a needle and here we go.
Right.
But the
That's right.
people who've had it injected is increasing.
Yep.
And it looks like the platforms or methods seem to be succeeding. We're making progress.
And also there's different ways of like it's not just gene therapy, like there's other types of treatments that are being investigated.
They're independent of each other.
Yep.
That are all slowly succeeding.
Yep.
So if we look a hop ahead, we think about in X amount of years, where do we think we're going? Where's this going to lead?
Well, we hope that there'll be options for everybody. I mean, that's what we want. You know, that
Personalised.
there's equity of access for people, you know, rural areas, other areas, you know.
So do we feel if we reach, I don't know, 10 years, whatever, if you've got RP, if you've got Stargardt, whatever, that the hope is starting to glow a bit stronger, that we may be able to say, we have got a treatment for you and it will make your sight better, and that will start becoming a real reality, TGA treatment, and here we go.
It's the aim.
And there's no reason to feel pessimistic about it at this stage, though. Things are getting better.
Yeah.
All right.
Yeah.
So, okay, I'm allowed to ask one more question. So there we go.
Maybe ask this before too, but for RP65, it's on market, right? Not clinical trial. So is government actually covering all the cost? So for all
Government is-
patients?
Yes.
It's amazing because, you know, in America, half
They have to
million
pay.
per eye.
Yeah.
So everybody in debt.
Yeah.
So
That's the reason that we're actually doing another research project that we haven't talked about, which is our health economics project, because we realise how important that is in the Australian system to aim to get government funding. And I think there's a real issue with non-understanding from government about the impact on families, you know, obviously both, you know, from psychosocial aspect, but also economic impact for the individual, for the family, and also the impact on society more generally. And so what this research project is doing is looking at those costs and then aiming to balance them against, you know, the costs of the therapy, because, you know, there is a cost to the therapy, but then to, you know, to be aiming to show that the overall cost benefit ratio is such that, you know, to give the therapy overall is much better prospect. So that's another project that's ongoing as well.
really appreciate all the work you've done anyway, you know, like I'm seriously appreciating everything. And I'm not gonna move into America.
Anytime.
I'm going to wrap it up, but I think I'm going to take that as things are getting better and you haven't hit any obstacles. The boat is getting faster. We're getting there. So this is good news. All right. Thank you very much, all of you. And no firing, not allowed.